Welcome to the deep dive. If you're gearing up for those big exams, FRCS, boards, maybe a fellowship, unicondylar knee arthroplasty, UKA, it's one of those topics, where getting the nuances right can really make or break things.
That's absolutely spot on. We're not just skimming the surface today. The goal here is really to equip you, the learner, with that high-yield practical knowledge. Think decision-making, controversies, management, stuff examiners really hone in on.
Exactly. And just so we're clear from the start, this whole deep dive draws heavily from the Ortho Made Simple notes. You can find them on the website, mokyingren.sg.
Right. Those notes were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, and he completed his FRCS in orthopedics from Edinburgh. Really solid stuff.
So here's the plan. We'll kick off with the must-know core indications. Then we'll tackle those tricky controversies, specifically ACL deficiency and patellofemoral joint OA.
Yeah, and after that, we'll look at complications unique to UKA, like bearing issues. And importantly, finish up with how you handle converting a UKA to a total knee replacement, TKR.
Okay, let's jump right in then. Success with UKA, it seems, really hinges on picking the right patient. Those ISACOS guidelines, they give us like 7 key factors, right?
That's the framework. You can think of them in 2 groups. First, 3 patient factors. These point towards someone who's maybe lower demand, generally healthy. So number 1, age, usually over 55.
Okay, over 55.
Number 2, BMI, ideally less than 30. And number 3, this is a big one. No inflammatory arthritis. So conditions like RA or gout, they're out.
Right, no RA, no gout. Got it. So that leaves the other 4 factors, which are more about the knee itself, the anatomy.
Exactly, the disease factors. You need minimal malalignment. For varus, that's less than 10 degrees, and for valgus, less than 5.
Less than 10 varus, less than 5 valgus.
Okay, then you absolutely need intact cruciate and collateral ligaments. Stability is key. Also, any flexion-fixed deformity, or FFD, needs to be less than 10 degrees.
And the last one. Didn't it used to be just pain limited to the medial side?
That was the classic teaching, yes. But, the alignment piece is where examiners often dig deeper. Unlike a TKR, where you might aim for perfect neutral.
Right. With UKA, it's different.
It's very different. The goal is not to fully correct the alignment. You're trying to avoid making it perfectly straight, but also avoid leaving it too bent. Overcorrection and undercorrection are both problems.
So is there a specific number we should worry about? Like how much residual deformity is too much?
Definitely. Residual varus, greater than about 5 to 7 degrees. That's the number to remember. The studies clearly show leaving that much varus significantly bumps up the risk of needing a revision later on.
5 to 7 degrees varus, residual danger zone. And what about ligaments during the surgery? Any absolute no-nos?
One huge one. Never release the medial collateral ligament, the MCL.
Yeah.
Ever. It's fundamental for the stability of a medial UKA. Releasing it just destabilizes the whole construct.
Okay, never touch the MCL.
Yeah. Now, this actually leads us nicely into the controversies, because while those 7 factors are, let's say, the classic starting point, indications have broadened a bit over time.
Okay. So where's the debate happening now?
2 main areas that you absolutely need to be ready for in exams: ACL deficiency and patellofemoral joint osteoarthritis, or PFJOA.
Right, the ACL. I remember learning it was basically a contraindication, full stop. But it's more nuanced.
It is. You really have to ask why the ECL is deficient. Is it a primary deficiency, meaning did it happen from trauma leading to actual instability, laxity you can feel?
Okay, but like an acute tear?
Exactly. That patient, the one with functional instability from a primary ACL tear, they should not get a UKA. The implant just doesn't have the inherent stability to cope with that.
But what if the ACL is just worn out, degenerated over time?
That's secondary ACL deficiency. This is often a chronic thing. The patient might have a degenerative tear, but crucially, they don't have clinical instability. They've compensated.
So they might have a deficient ACL on MRI, but the knee feels stable.
Precisely. And for those patients, studies are showing good short to midterm results with UKA. So the deciding factor isn't just the MRI finding, it's the clinical stability. If the knee is unstable, UKA is off the table.
Okay, that distinction is key. Primary unstable, no UKA. Secondary, stable, maybe okay. Now, what about the PFJOA? This one seems really interesting.
Oh, it is. The old thinking was pretty much any sign of PFJOA, especially anterior knee pain, meant you had to do a TKR.
Yeah, I remember that rule.
But then came studies like the Hamilton paper in JBJS. It was a 15-year follow-up, specifically on mobile-bearing UKAs, and it really forced a rethink.
So what did they find? What's the new thinking?
It turns out the location of the PFJ-OA matters much more than just its presence or even severity in some areas.
Mm.
The critical point is the lateral side of the PFJ.
The lateral side. Why this specifically?
Because significant arthritis on the lateral facet or the lateral trochlea often suggests a bigger underlying issue, maybe patellar maltracking or more global arthritis that a medial UKA just won't fix. So severe lateral PFJ-OA remains a contraindication. You'll likely end up with persistent lateral pain.
Okay, so lateral PFJ damage is bad, but what if the arthritis is on the medial side of the patella or trochlea?
That's the surprising part. The Hamilton study showed that even severe OA changes confined to the medial side of the PFJ didn't seem to affect the functional outcome or the implant survival rate at 15 years.
Really? Even if it looked bad on the x-ray?
Even if it looked bad radiographically. And maybe even more surprising, the study found that just having preoperative anterior knee pain itself didn't predict a worse outcome or lower implant survival.
Wow. So the symptom alone isn't the deciding factor. It's about ruling out significant lateral compartment PFJ disease.
Exactly. It shifts your focus during assessment.
Okay, let's switch gears to the implants themselves. Fixed versus mobile bearings. You hear arguments for both. What are the real trade-offs?
Yeah, it's a common point of discussion. Overall, revision rates are actually pretty similar between the two designs, but how they fail and their technical aspects are different.
So the fixed bearing first.
Okay, the fixed bearing. It usually has a flatter polyethylene surface. The idea is that it allows for slightly more natural, less constrained knee movement, mimicking normal kinematics a bit better.
Sounds good, but what's the catch?
The catch is higher contact stress. Because it's flatter, the force isn't distributed over as wide an area. So the main way fixed bearings tend to fail over the long term is polyethylene wear. The plastic just wears down faster.
Okay, more wear with fixed. What about the mobile bearing?
The mobile bearing uses a more curved, conforming poly insert that actually moves, rotates a bit on the tibial tray. This high conformity spreads the load out better, reducing contact stress.
Less stress, so theoretically less wear.
That's the theory, yes. But the downside is, first, it's technically a bit harder to balance and put in correctly. And second, its unique failure mode is dislocation. The classic bearing can actually pop out of place.
Ah, dislocation. And that leads us to some pretty stark numbers, especially comparing medial versus lateral UKO.
Absolutely stark. If you look at medial UKAs, bearing dislocation is pretty rare. Maybe 1 in 200 cases, something like that.
Yeah.
And it usually goes anteriorly if it happens.
1 in 200. Okay. But lateral UKA.
Lateral UKA. The reported incidence is up to 10%.
10%? That's huge. Why such a massive difference?
It all comes down to the ligaments and how they behave in flexion. On the medial side, the MCL stays tight pretty much throughout the range of motion. It provides constant stability.
Okay. MCL is always on guard.
But the lateral collateral ligament, the LCL, it naturally becomes slack when the knee bends into flexion.
Ah, so it loosens up.
Exactly. And that slackness provides much less constraint laterally in flexion. So if the components aren't perfectly positioned or the soft tissue tension isn't quite right, that mobile bearing on the lateral side has much more opportunity to escape, often slipping out posteriorly or laterally.
That makes sense. So if you encounter a dislocated bearing, what's the management plan? What are the steps?
You've got a few options, usually escalating. Option 1, try a simple bearing exchange. Put in a larger, thicker polyspacer to increase stability.
Okay, bigger bearing first, if that doesn't work.
Then you might need to revise the UKA itself. Maybe change the components slightly, or perhaps switch from a mobile to a fixed bearing design if you think that offers more stability.
Revision UKA is option 2. And the final step.
If instability is severe, or revision UKA fails, then it's conversion to a total knee replacement. And crucially, you must have revision TKR kit, especially constrained options, available just in case when you go in for any UKA revision or bearing exchange, you need to be prepared.
Always be prepared for conversion. Okay, good point. Let's just quickly remind everyone listening, we're working through these key points based on the Ortho Made Simple notes you can find over at mokyingren.sg. Great resource.
Definitely. Now, thinking bigger picture again. How does UKA stack up against another common procedure for unicompartmental arthritis, especially in younger patients? The high tibial osteotomy, or HTO.
Yeah, that comparison comes up all the time. What does the evidence say long term?
Well, there was a big systematic review by Dettoni and colleagues, and interestingly, they found that the mid- and long-term outcomes were actually quite similar. 10-year survival rates for both UKA and HTO were hovering around 80%.
80% survival for both at 10 years. So if the results are similar, how do you choose?
It really comes down to the patient profile and the surgical goal. HTO is generally seen as better for younger, more active, higher demand patients, people who might place more stress on their knee.
Right, the active group.
And technically, the goal of an HTO is completely different. With HTO, you are intentionally overcorrecting the alignment. If it's a varus knee, you make it valgus to shift the load completely off the damaged medial side onto the healthy lateral side.
Okay, HTO overcorrects, but
Yeah.
UKA.
UKA, as we said, is usually for lower demand patients, and you're specifically trying not to significantly alter the overall alignment. You're just resurfacing the damaged part.
So different patient, different goal. And does this difference show up if you have to revise them later?
Massively. Revision surgery after an HTO can be tricky. You often have higher complication rates. Things like infection risk can be higher, mainly because you've got previous hardware, maybe altered anatomy, and often need more extensive soft tissue dissection.
Okay, HTO revision is complex soft tissue-wise. What about UKA revision?
UKA revision or conversion to TKR often has fewer soft tissue issues, but it presents a different major challenge: bone loss.
Bone loss. How bad is it usually?
It's often quite significant. There's data showing that around 77% of UKA revisions required some form of osseous reconstruction. They couldn't just use standard primary TKR parts.
77% needed bone augmentation.
Wow. Yeah, meaning they needed metal augments, sometimes stems, sometimes bone graft, because the original UKA components, especially the tibial tray, can lead to substantial bone loss underneath them when they fail or are removed.
That's a huge number. Which brings us neatly to that critical exam topic, the steps for converting a UKA to a TKR. There's a mnemonic for this, right?
Yes, the EER mnemonic. Really important to know this code for your exams. It covers the key intraoperative stages.
Okay, let's break it down. EEERR, what's the first E?
First E is extend. Extend the previous surgical incision to get adequate exposure.
Extend incision. Second E.
Explant. Carefully remove the existing UKA femoral and tibial components.
Explant components. Third E.
Examine. This is crucial. You need to carefully examine and assess the resulting bone loss. Usually, you'll classify it using a system like the AORI, Anderson Orthopaedic Research Institute classification.
Examine and classify the bone defect. Okay, that covers the ES. Now the R's. First R.
Reconstruct. Based on your examination, you reconstruct those bone defects. This usually involves using metal augments, wedges, or occasionally bone graft to restore the joint line and provide a stable platform.
Reconstruct the defects. And the final R.
Replace. Replace the joint with your chosen TKR system, applying principles of zonal fixation. Given the bone loss we just talked about, this often means considering using stems on the tibial or femoral side, or both, to achieve better stability in the metaphysis.
Replace with zonal fixation, maybe stems. Got it. EER. Extend, explant, examine, reconstruct, replace, and post-op after that conversion.
Generally, if you achieve good stability with the reconstruction and the revision TKR components, you can allow full weight bearing as tolerated, FWB-AT, pretty much straight away.
Okay. Now let's talk about another complication, one that can happen after the UKA is done, a fracture of the tibial plateau, specifically the medial side under the component. What makes this more likely?
Right, the post-UKA medial tibial plateau fracture. It's a known risk. We can group the risk factors. First, there are patient factors, things like osteoporosis, obviously, weaker bone, and it seems to be more common in female patients.
Osteoporosis, female gender, any anatomical risks?
Yes, a key one is proximal tibia vara, where the upper part of the tibia itself is bowed inwards.
And why does that increase risk?
Because that bowing can effectively reduce the amount of good bone directly underneath the medial tibial component. You have less bone stock supporting the implant, creating a stress riser.
Less bone support. Makes sense. What about things the surgeon does? Technical factors.
Oh, definitely several surgeon technical factors. Things like inadvertently damaging the posterior cortex of the tibia during bone preparation, or cutting the tibia too vertically, or taking off too much bone medially vertical overcutting.
Okay, posterior cortex damage, overcutting.
Also, where you place the pins for the cutting block matters. If a pin site is poorly chosen, it can create a weak spot. And there's some thought, particularly with cementless UKA, that if you aim for too much press fit, that interference fit, and then impact the component aggressively, that combination might increase the immediate fracture risk.
Right, aggressive impaction with cementless could be an issue. So if this fracture actually happens, how do you manage it? What determines the treatment?
It really boils down to two things. Is the UKA implant still stable, and is the fracture displaced?
Okay, stability and displacement.
So if the fracture makes the implant unstable, you really have no choice but to revise. That usually means revision to a more constrained UKA, if possible, but often it requires conversion to a TKR.
Unstable means revision. What if it's stable?
If it's stable and undisplaced, you can often manage it conservatively. Strict non-weight bearing, allow the fracture to heal, and hope the implant remains solid.
Stable undisplaced. NWB. What about stable but the fragment is displaced?
If it's stable but displaced, the usual recommendation is operative fixation, typically using a buttress plate on the medial side to hold the fragment reduced while trying to keep the existing UKA components in place if they're well fixed and well positioned.
Plate it, but save the UKA if possible.
Gotcha. Okay, so we've covered a lot of ground. Those isocos factors, the detailed look at ACL stability versus instability, the location focus for PFJOA, that surprisingly high 10% lateral bearing dislocation risk, and the EHR steps for conversion, which often involves dealing with that 77% rate of bone loss. Getting these specific points clear is really going to help, especially the numbers like the 5-7 degrees varus limit.
Absolutely. And perhaps a final thought to leave you with, something to consider as you synthesize all this. Given that very high rate of significant bone loss needing reconstruction when UKAs fail that 77% figure again, how should that influence your initial thinking when choosing between a cemented versus a cementless UKA, especially in a younger patient? What approach might best preserve bone stock for the long haul, anticipating that future revision might be needed decades later? That's a great question to ponder. And remember, everyone, this entire deep dive has been based on the excellent Ortho Made Simple notes, which you can find on the website mokyingren.sg.
And as you press on with your studies and your work, always remember this encouragement. From the fruit of his mouth, a man is satisfied with good, and the work of a man's hand comes back to him. That's from Proverbs 12.13.